Support for WBFO and What's Next comes from our members and from Health Foundation for Western and Central New York, where racial and socioeconomic health equity are prioritized. Learn more about building healthier neighborhoods at hfwcny.org.
From Buffalo Toronto Public Media, this is What's Next, an hour dedicated to amplifying the voices of marginalized and underrepresented communities across Western New York and Southern Ontario.
We cannot erase, we cannot reform, we cannot make things better if we're uncomfortable having tough conversations,
Absolutely.
if we're uncomfortable talking about race.
What's Next carries forward our mission to engage in meaningful conversations about race, equity, and the shared concerns that deeply affect Buffalo's East Side and beyond.
Don't stop. Make those families part of your life. Their lives are part of yours. Don't stop.
Together, we dive into the real issues, striving for understanding, connection, and change.
In the suburban area, everywhere, we must work and teach our children.
And good morning. Welcome to What's Next. And actually, we're going to be talking about education this morning on What's Next. We're going to actually get into the field of nursing. And there's a lot of interesting issues related to this, not the least of which is nurses among the highest rated when it comes to honesty and ethics in any profession. Name your profession. The nurses stick up at the top of that. 3 out of 4 Americans, as a matter of fact, say the nurses are highly honest and ethical. We're going to get into that subject and more when it comes to nursing with Dr. Annette Wysocki. Dr. Wysocki is the Dean of School of Nursing at the University of Buffalo, and she joins us this morning. Good to see you, Doctor.
Good morning. Nice to meet you. It's great to be here with you.
Absolutely. There is a lot in this particular topic here that we're going to get into. And I'm thrilled because your experience really runs the gamut here to a certain extent. And let's just take a moment to dive into it. Though I call you Dr. Wysocki, you got into this field as a registered nurse, correct?
I did. I started my career actually after graduating from nursing school in North Carolina. I went to University of Virginia in Charlottesville and began my career working on an oncology surgical unit and then worked in a burn unit there. And that's, of course, what then led me to eventually have a research career in wound healing, research and making some discoveries that then impacted how we care for wounds today.
When I talk about the honesty and ethics and these polls, what do you think about that? What do you see in terms of a connection between what a registered nurse is doing on the front line and what the perception of the public is? How does that make sense to you that nurses stand out above lawyers, doctors, teachers?
Well, I mean, it seems very obvious to us, I think, in nursing, and I think that's because, as you may know, 86% of the face-to-face time with a patient is with a nurse. And so we are the ones that are continuously there 24 hours a day, 7 days a week, 365 days of the year, taking care of patients. And so we come to observe your health condition. We know if things aren't going well for you. We understand what are the treatments that we are responsible for delivering, as well as the care that we provide independently on our own. And so because we are there listening, watching, observing throughout that time continuously, then that's why we, I think, are the most trusted profession, because patients know they can depend on the nurse who is there 24 hours a day should something arise or they have a concern and or a deterioration of their condition. So I think that is why it's more than well-deserved that we have been trusted for so long by the American public. And actually, it's been for more than 20 years, and actually longer than 20 years, with the exception of the year of 9/11 when it was firefighters. And even up until that time, nurses were also rated the highest. So we again, are the ones that are there to really monitor what's happening. We're sort of like the canaries in that coal mine.
And I want to be kind of careful how I phrase this particular question. I don't want to make cast a wide judgment when it comes to the medical field, but I would think, in a lot of ways, overall, when it comes to medical concerns or healthcare issues and the treatment thereof, that the overall field probably doesn't get that high of a mark when it comes to ethics. And I even see I think doctors, going back to the same poll, I see that they have fallen 14% in this very poll as well. Again, compare and contrast what's going on with that. Nurses, people think highly of them, but yet maybe their surroundings aren't as well, seen as honest or as ethical. How do you make that? What do you make of that?
Well, I think it's probably the perception of patients is that physicians are there just intermittently for very brief periods of time, and so they don't understand that the care and concern and the empathetic compassion is there from physicians, and I think they then see them as not. And then I think also they're sometimes directing or instructing or telling them things without giving them an opportunity to ask questions and or to voice their concerns because they are doing it in such a rapid pace. I think that's where nurses have a real role to play because patients are in a very vulnerable situation when they're in an unfamiliar environment, and especially if they've not been hospitalized before. So nurses are the ones that can help understand what are their concerns, help them understand what are the questions they should be asking, what are the things that they need to know, and how to return and restore their health. So that's also one of the major differences between physicians versus nurses is physicians are focused on the diagnosis and treatment of disease. Nurses are focused on the promotion and restoration of health. And that's our primary calling. And so, of course, when you think about the time of a patient in the hospital, you are there primarily for nursing care. That is the bulk of the care you receive is nursing care.
Yet I would say most people don't think of it that way, do they?
No, they probably don't. I mean, they may be there for a surgical procedure, but once the surgery is completed, then it's the nurses who are helping you promote and restore you back to a healthy situation so we can discharge you, send you home, do whatever the necessary follow-up care is with a home care nurse, and or to help you then return to, living.
Take me through. I know it's been probably a while since you've been on the floor, so to speak. Mm-hmm. But to take me through what a nurse might do in their 8 or I know 10, some do 12-hour shifts these days. Take me through a little bit of what that might be like.
Well, I think most people, depending on the facility where you're at, you might start off your shift with a verbal report or a handoff, depending on if you're a critical care versus a unit. And so usually there's somebody that's handing off, they are going to you and you're saying, okay, here's the patients I'll be taking care of today. We go over what are the conditions of the patient, what are their treatments that we need to make sure we're managing and delivering for the patients, whether it's a wound care treatment, whether it's watching vital signs, what are the drugs and therapeutics that will be delivered to the patient. Have there been any responses that have not been normal? So we start off usually our day with understanding as we're doing a handoff from one shift to the next, and then each nurse always goes in and assesses that patient at the beginning of their shift to understand what is their current condition, has anything changed, is there anything I need to do immediately, so we can automatically start to prioritize amongst the patients we're taking care of. I can give you a for instance. I remember one time I've been through many nursing shortages, and I have to say, I remember I'm receiving report, and for some reason I was one of the more experienced nurses at the time, and I've got every difficult patient there is. I have one patient who's decompensating with oxygen saturation, needs to go to ICU. I have another patient who has a brain tumor and is throwing up, and you're concerned about what's going on with them. And then I have one other person who's being treated for cancer and needs platelets.
Wow.
So automatically I have to prioritize. So after getting report, I quickly assess the person. For me, the person who was decompensating with their oxygen and needed to go to ICU to be on a respirator, they had a family member in the room, and I checked on them. They were at least alert, they were oriented, and even though they were not in the best of condition and they were turning a little bluish, they were cognizant. I walked into the patient who with the brain tumor who was throwing up. No one was in the room, and the patient was on their back. And then you're concerned about aspiration. So I turned this patient on their side so that they could, be safe while I was doing other things, making sure checking with them, because I'd also checked on the patient who needed the platelets. And again, at least they were alert oriented. And yes, they needed to get the platelets, but it wasn't an emergency that needed. So sometimes these are the types of fast-paced environments where nurses have to make snap judgments about which patient you need to prioritize and who needs what kind of care, and then recognizing that safety. So then throughout our shift, we're constantly, taking care of these patients in many ways. And again, I've worked in, as I think I might have mentioned, I worked in a burn unit as part of my early career. And of course, sometimes that is so intense because you're also in my time in working in the burn unit, I also did wound debridements. And we used to use Hubbard tanks where we would take the patient to the Hubbard tank and debride these wounds. The nurses did all of that work. And so you're constantly prioritizing what you need to do, whether you have, wound care that you're taking care of. And many of the, those decisions around wound care, or nurses are deciding what types of dressings and treatments might be needed to care for that wound. So throughout the day, you're prioritizing whether they might need, and coordinating with the other members of the healthcare team if they need, if they're an asthmatic or COPD, do they need a respiratory treatment? Is the respiratory therapist supposed to be there? Is the physical therapist supposed to be there? So you're making sure and coordinating the entire healthcare team for every patient you're taking care of. So it's very fast-paced environment today. And so that's typically, and then we go through our entire shift monitoring, always looking at your vital signs, checking, making sure there's no complications, and then reporting on to the next shift who comes behind us. So that's just sort of a little sampling, perhaps, of what might happen on a shift.
It's a breathtaking amount of work and responsibility. I think that's what really stuck out there, that you are making these decisions, and I don't want to discount the teamwork involved, but I'll probably reference more than once in this program, I spent many months in recent years with my parents in hospitals and saw a lot of this. But nurses were available, trying to track down a doctor. And I don't want to sit here and criticize doctors and make it sound like that. But the point is, you're trying to you work with a team. But yet at the same time, that team also might be scattered about and doing all sorts of other things. So you have to make these types of decisions. That's quite a responsibility.
No, it is a huge responsibility, which is why the level of education has, greatly improved. I mean, at the turn of the century, of course, nursing was almost like an apprenticeship. And then it was in the when the Goldmark report came out, which was in the 1918, 1920, in that period of time was one of the first reports that came out that then started moving nursing from sort of an apprenticeship system into a university setting. And also along with that, it's parroted along with the types of therapeutics, the drugs that have been developed over time have become so much more. Sometimes, we are titrating those drugs. We're balancing patients on the edge of life, literally, when we are, especially in critical care areas where we're looking and monitoring blood pressure changes and deviations. And we have a dosage of a drug that a physician has prescribed, and we're deciding exactly how much of that drug to be delivered to that patient, because every patient responds differently. And we know that in some situations, men can tolerate higher doses of a drug than women patients in certain situations. But it's the nurses who observe your response to that therapeutic drug to understand exactly how much to give. And so those are the situations where we are the keen observer of the physiologic response to the therapeutic treatments that can make the difference.
That idea of the dosages of drugs, you told me that before we went on the air, and it's a fascinating part. And again, I'm asking just a conjecture, but how many people outside the nursing profession, and I guess obviously anybody else who works inside the medical profession, would know that nurses are the ones that you say the doctors prescribe, but the nurses figure out the dose.
Yeah, it's not true for every drug that's given. Okay, for a lot of oral agents and pills and things, yes, that is a set dosage. But I'm thinking about especially drugs that are managing, again, for critical care areas that are given IV.
Right.
That IV dosage is not always clear because, it depends on your body weight. And again, your individual response to the drug. And then, more and more, of course, genetics is coming into this too. And we know that some people don't metabolize drugs in the same way. And of course, we're sometimes the astute observers of that response. And we haven't moved to that super point of medicine yet where we are looking at your genetics to understand whether or not you'll respond to a drug in a certain way.
Are we going to get there, do you think?
We're getting there.
Yeah?
And we are there in some ways for some drugs. We do know that. But in other situations, we're not doing that screen routinely for every patient,
Sure.
But yeah, so I would say mostly these are agents that are given intravenously in the vein to a patient. Those are the ones where we're titrating doses. And sometimes it's true for pain medications as well, especially, again, if it's an injectable drug or an intravenous pain relief that's being given. Again, we are trying to manage. I mean, I think of another situation where a patient I had came from the recovery room. Somebody had given them some pain relief, but gave a little bit more than they should have. And here's this patient, and, breathing is diminished. They're having like 3 or 4 respirations a minute. They've got pinpoint pupils, and I know right away that this patient needs a dose of Narcan.
Okay.
And so I'm calling the physician on the phone. He's busy attending to emergency at another hospital. And he's like, what does this patient need? And I said, amp of Narcan. He says, do it. And, so I moved right away to deliver that to the patient to get them back to a stable situation so they had a routine respiratory rate and weren't in trouble. And I remember this physician coming by after his emergency room. And again, this is where sometimes their physicians are trying to manage other emergent situations.
Of course, yes.
And he came and he was just, flowing with compliments about, I'm so glad you were here. I'm so glad you picked up on this and that you observed this. And that's what nurses do. And I think sometimes we take it for granted what we do. And it's sometimes unseen to the public. In many ways, and under that understanding of what actually we are doing. And I think we do it in a way that we don't alarm patients because it's part of the routine of what we do.
We're talking with Dr. Annette Wysocki she's the Dean of the School of Nursing at the University of Buffalo. We're talking about the nursing profession, some of the perceptions about it. Interesting to find out that most Americans think that when it comes to honesty and ethics, nurses stand on the top. That's good to know. But at the same time, back to what you're saying about the patients, I think that's interesting. A patient really, although obviously very appreciative of what nurses are doing, they might not even know how much the nurse is doing. I'm wondering if there's even like this, I know we're in the year 2025, but I'm wondering if there's like a lot of still kind of old perceptions that, well, the nurse is, this, person who's just going to come in and, do a couple little things, maybe, change my pillow, whatever, I don't want to soft, but I don't want to do it. But are there still those perceptions that the doctor's the person who is the overseer and the all knowledgeable person, and the nurse is, they're here to help me. I appreciate it. But at the same time, maybe they don't understand the depth of all that goes into that profession.
No, I totally agree, of course. I mean, I think, again, it's a team effort. And again, we are the ones that are also recognizing, when you might be getting into trouble. We're monitoring your breath sounds to know if you're developing early signs of pneumonia, whether or not your lungs are clearing, all of those things that we do. And actually, we may be in there adjusting your pillow, but we're observing you,
right,
your body, and your physiological response simultaneously. And, whether it's multiple, sometimes in critical care areas where you're hanging, might be receiving intravenous fluids, and we're also managing 3 or 4 other drip medications that you're receiving. And again, monitoring those to make sure that you are receiving those in a way that don't drive you into a deterioration. So it's, I think you're right. I think that people don't understand that while, yes, they are doing their part, we're also practicing under our nursing license where we're looking at your physiologic response. And then also we're trying, again, as part of our promotion and restoration of health, trying to help you to get up, move, circulate the blood, understanding that you need to breathe and making sure you're inhaling, taking deep breaths, doing things that are going to help you restore your health. I do think that one of the areas that, all nurses and patients probably distress over is adequate sleep in the hospital.
Right.
But that's so important. And yet hospitals can be noisy environments. And so I think that's been one of the things that nurses have also tried to be attuned to, is trying to create environments to provide better rest and sleep at night, and then not unnecessarily, managing and timing your treatments during the night so we're not unnecessarily waking you or disturbing you. If things, if we can alter some of that scheduling over the night so you can sleep, because we know that during stage 4 sleep, that's when growth hormone is secreted, which for people especially that have surgery, that's important for tissue healing.
How far do we have to go to get to stage 4 sleep? I'm curious about that.
I don't know that they refer to it as stage 4 sleep anymore, but in the old days, for sure, it's just that's the deepest stage of sleep, when you just really think of the times when you might have just gotten so exhausted from physical exertion during the day that you put your head on the pillow and you are gone.
Right.
Then that, again, is when your body is having those really deep stages of sleep that are restoring. And again, that's when growth hormone is secreted during those deep stages of sleep. That's so important to restore your health.
I feel like I don't want to keep putting you on the spot, and I hope you don't feel like I am, but I just get the sense as you're talking that nurses have a great understanding of all the needs that are going on their particular units, their hospitals. Are they getting enough input into the way hospitals are run and hospitals are constructed and organized?
That is an excellent question, because that is one of the major problems, in my opinion, is that nurses don't have enough input into how the care is delivered. And, every hospital board should have a nurse.
They don't?
Many of them do not. If you look at these hospital boards, they might be people in the community but every hospital, every medical board should have a nurse on, because today it's not just physicians that are caring for patients, it's physical therapists, nurses. So it shouldn't be a quote, quote, medical board. It should be a hospital board where everyone, or a professional board, where all members of the healthcare team have a voice in making the policies that are going to help operate this hospital. And for far too long, that voice has been a singular voice. But in reality, nurses are the ones that really are operating the hospital, making it work. We are the backbone of the healthcare system. But I think it's also because it's still a primarily women's profession. We have the same lack of acknowledgement. Often our patients acknowledge us and see it better than our colleagues do at times. But I think, as with teachers, nurses, social workers, librarians are probably the people that are the least recognized and sometimes appreciated for what we do for our communities, and also the least supported. But I do think that's an excellent point. And if one of the experiences that I had when I was at the National Institutes of Health as the scientific director for the National Institute of Nursing Research, I was also for a while the clinical director. And because the clinical center at the NIH is run quite differently, because it operates off the budgets of all of the other institutes, then each institute has a voice on that medical board that was there at the time. So I was the nurse on the medical board. We had a dentist on the medical board. Most of the other people on that medical board were physicians from the other institutes. But when we were making decisions about the policies, what would be happening at the clinical center at the National Institutes of Health, we all voted and had a voice on those. And I can remember a few times when some decisions were made where I and my dental colleagues were the tying and deciding vote.
Wow.
And so, because there was disagreement even among the physician colleagues. But I always voted based on, principles and ethical centeredness of what the issues were that came before the board. But it was an instructional moment, because it made me realize that we are behind the times. The clinical center at NIH in some ways has led, where I feel like the future lies in healthcare, where other voices who are also caring for these patients as a team need to be be making some of these decisions that are affecting some of how we deliver care to patients.
And you did get into it just a second ago. Still mainly female profession.
Yes.
Do you have any idea what the statistics are on that?
Yeah, so currently there was a time when about 9% of nurses were men, and then currently that number's actually come up to almost 12% now, men. And I would say here at University of Buffalo, actually, we're doing a little bit better than that. We have about 15% of our students are male students, so we are ahead of that curve. And I think largely because today more men are coming into nursing because they want to move along the pathway of becoming an advanced practice provider as a nurse practitioner, whether it's a family nurse practitioner, adult gerontology nurse practitioner, pediatric nurse practitioner, a nurse anesthetist, or a nurse midwife. I mean, there are many other advanced practice roles in nursing now, and I think that's starting to attract a lot more men into nursing. When I poll our students when they come to our School of Nursing at University of Buffalo, I often ask them, what do you want to do? And then I ask them, what if they have any idea. And then sometimes I say, and how many of you want to be nurse practitioners? And almost every hand in the class goes up.
Really?
So I think many people are, and I think it makes sense for many reasons as the therapeutic advances have been made around genetics and the types of drugs we're delivering, immune-based therapies today. That level of education and that level of how we're going to be delivering care needs to be leveled up. And so in some ways, we maybe reach a time far into the future where every nurse is a nurse practitioner.
Wow. Well, you left me on an intriguing point, but we need to take a break. We'll come back and talk more about that. A lot to get into, as you can hear, when it comes to nursing. And we have the right person here, the Dean of the School of Nursing at the University of Buffalo, Dr. Annette Wasaki. We're going to take a time out, come back with more on What's Next. This is What's Next on WBFO.
Our mission at Buffalo Toronto Public Media is to serve our local community. And on WBFO, we do that by keeping you informed and connected to your community, whether it's by hearing from a local Black poet about what it was like to move from the inner city to the suburbs on What's Next.
So that emotional change with that culture change combined let me realize that basketball and being physical wasn't enough. I needed a way to figure out my emotions. So the first poem I wrote in the cafeteria of Sweet Home Middle School was Outcast.
Or it's exploring the East Side Garden Walk.
It's wonderful that we're seeing engagement in beautification and sharing gardens, because we believe that we can build more vibrant communities by sharing our gardens, by sharing our stories, and by building real connections between people. We came through as neighbors and cleaned this space out and began plot by plot putting plants in.
This is Public Media.
From the fringes of the mainstream to the local music you love, listen to WBFO The Bridge Monday through Thursday, 8 p.m. to midnight on WBFO 88.7 or your smart speaker.
You're listening to What's Next, our place to discuss the important issues of our communities of Western New York and Southern Ontario. We want to hear from you. Click on the Talk to Us option in the WBFO app, and we'll work to get your questions or comments on the air. Do you have a story or concern that we should be addressing? Email us using what'snext@wbfo.org. Together, we'll have the conversations that are needed. This is WBFO, your NPR station.
And this is What's Next on WBFO. Dr. Annette Wasaki, Dean of the School of Nursing at the University of Buffalo, with us this morning. We talked a little earlier about how Americans see nurses at the highest regard when it comes to honesty and ethics. Yet there are other issues inside the nursing field that are, I think, kind of not, I guess, in some ways, stand opposite that, and not the least of which is the nursing shortage. According to one study, by the year 2027, this country is going to be 300,000 short when it comes to registered nurses. Is that right?
That's correct. So we have a potential looming shortage of registered nurses, and largely because we don't have enough faculty in schools of nursing.
Oh, okay.
And so that's each year we turn away, we could easily, there are many people that apply, but we also turn away people that we would have accepted, but we don't have the faculty. So each year we turn away at least 65,000 students every year from schools of nursing because of inadequate numbers of faculty. Sometimes we don't have enough classroom space. Sometimes we don't have enough clinical placements with our clinical partners. And, and then we just don't have, again, the resources to educate students. So that's one of our primary issues in nursing is the inadequate resources.
There is an interest. There is enough people interested?
Oh,
to becoming a nurse?
absolutely.
Okay.
Absolutely. I mean, every school of nursing could probably take double the numbers of students that they do easily.
Okay. How many people apply to your school of nursing?
We have a pretty large number of applications, and I have to say the scientific rigor required to be a nurse today is unlike in prior times, and again, it's because of the advanced therapeutics and all of that. So we accept quite a number of students into UB, and I would say for us somewhere between 20 to 40% or more sometimes of these students, they cannot pass the science requirements. So nursing today is while it's holistic. Nursing is about the science, the physiology, the biochemistry. It's about pharmacology, and it's also as well about the social needs of patients, which are the humanities. So I tell my nursing students when they come that there are 3 things they have to accomplish. They have to be a scientist, they have to be a humanist, and they have to be an ethicist to be a nurse.
Wow.
And those are what I tell students every year when I welcome them to the School of Nursing, because it requires all of those dimensions in order for you to become an expert, proficient nurse to deliver care that's compassionate and then, again, is driving the recovery of those patients and promoting their health.
During the pandemic, we heard about nurses getting burned out.
Yes.
Getting out of the field. Yeah. What was at the core of that?
I think a lot of that was because, one of my colleagues, and you might have heard this in the press, where a lot of nurses feel like we went from heroes to zeros. And that is that we were there doing things that no other member of the healthcare team was doing often. We were the only ones going into the room to see the patient, to hold the patient's hand, to try to communicate with families during some of the worst parts of the pandemic. I remember a nurse I was not here in Buffalo, I was out on Long Island at the time, and I remember one of the faculty at the School of Nursing talking about, who was also a nurse practitioner working in critical care and, of course, taking care of these patients with COVID. And she's talking about how she's writing things, pasting signs onto the window, the physician's behind the window, not in the room, asking for orders, telling him what this patient needs to write an order so she can give a drug or do something for this patient. How nurses had to innovate around doing things like they were the ones who were using iPads, using cell phones to try to at least have communication between patients and families. Nurses were also innovating around understanding, okay, if I take and put on multiple extensions onto my intravenous fluid tubing, then I could put some of this outside so that it can minimize some of the time for people to be in the room to create, and then also for the pharmacy and other people to try to help manage some of those drips that are going on in the room. So I think it's those times, because nurses do some of the most, that's where I'm talking about the humanism and the ethics of nursing. We do some of the hard emotional work with patients, and that hard emotional work is helping people sometimes make life or death decisions for themselves in the most extreme situations. I can remember another story from another faculty member I had who also was a nurse practitioner working during the COVID, where it turns out that both a father and a son came to the hospital, and they just, the father's like, well, my son's here. So she got both the father and the son together in the same room. Unfortunately, they both expired during the COVID pandemic. But again, it's that attention to trying to make the worst situation the best possible. But it's an emotional work that we do with patients during this time, and especially when things aren't going well, and then trying to reckon with your own death is not easy. But nurses are the ones who are often having those conversations with patients, and that's where the humanistic and the ethical aspects of what we do are so important. And we're also trying to meet patients on their terms, not our terms, not how we grew up and our orientation to the world, but trying to understand what is your orientation to the world, what are your values, and then helping you reflect and understand how you can meet that on your terms.
As you were talking, this struck me, and I'm wondering how you feel about this. As somebody who was a nurse and going through, you were just talking about these COVID situations, and we all knew some. I think all of us had some connection to situations like that where people were lost. That was 5 years ago. The COVID pandemic was 5 years ago. There seems to be, and this is my impression, and I'm guessing asking if this is your impression as well, that there's kind of a mainstream dismissal of how serious that time really was. And knowing nurses who were involved in this and being a nurse yourself, how do you accept that?
I think it's, I think it's been really difficult, and I think that's what has led to a lot of burnout and turnover, because you felt like many nurses sacrificed a lot of time with families. I think of some of the extreme things that all members of the healthcare team were doing, like being so concerned before we had vaccines, where we were undressing out on the porch or in the garage, before, taking a shower. In some cases, I know of people who lived in the basement and didn't even interact with their family. They were so concerned that they might, introduce a respiratory virus to the family. So they were living in the basement, in a garage apartment, or apart and away, just to ensure that their families survived. So I think nurses are people that make incredible sacrifices for patients in all sorts of situations. And I think that, again, that led to burnout, turnover. And then I think nurses saying, and where is the support that other physicians receive abundant support at various federal levels, but nursing is not supported in the same way that medicine is supported at the federal level, with funding from the National Institutes of Health, with graduate medical education payments. Some of these things where there's lack of recognition of the importance, and we don't have the number of endowed professors, endowed chairs, endowed scholarships. I mean, you think about people who have given money so that physicians and medical students could have a free education. Who has done that for nursing? And that's where I think nurses say, are we less important? So you start to feel like there's a hierarchy that's evolved that is no longer relevant in this day and age. And so it's that lack of support for the nursing profession, be it through philanthropy or support at the federal level, where we don't receive that support and others freely seem to give it to others. And I think that's where not feeling that level of support for the people we work with, and or how to turn that trust of the public into actual meaningful support so that we can continue on as professions.
Well, you're kind of leading us to this, Doctor, and the idea that in 2027, so we're just 2 years away, the country is going to be 300,000 short of registered nurses. You mentioned and, of course, told us how it's not so much that people aren't interested in becoming nurses. There's just the education paths just do not exist. Let's talk about the fact that when it comes to donations to the health system, that 1% of all donations that go to healthcare fields go to nursing programs. These schools need more funding if they're going to train more registered nurses. True?
Absolutely true. So, I think that's where, there's a place for private philanthropy as well as a place for government support as well. Think about, I've in just a couple of the School of Nursing at UB dates itself to 1936.
Okay.
Very soon we'll be celebrating our 90th birthday. The School of Nursing has never had a designed, purpose-built building for the School of Nursing at UB. So this is where, but yet, this is where you see other disciplines that have had buildings built for them, designed and built for them. And the School of Nursing has never had a building designed and built for them in 90 years at Buffalo. And I think that's not unlike many schools of nursing. There are some states that are investing, and so this is where states need to step up and support. New York State educates the fourth largest number of registered nurses nationally in the nation. And so we have a big role to play here, and so New York State needs to also also be investing in nursing and in schools of nursing, be it facilities for classrooms. That's another one of our dilemmas right now. We've been increasing our enrollment, and our classroom space is no longer adequate for the size of our classes. Where are we supposed to go? Well, we're going across to another building on our campus to try to find space large enough for our students. Yes, we want to continue to expand and grow the program, but we need larger classroom space. So that level of support is what also drives. So whether it's and again, I know it's also addressing this at the federal level where 1% of that philanthropic dollar goes to nursing, but at the federal level, when you look at the National Institutes of Health budget, the National Institute of Nursing Research doesn't even receive 1% of the NIH budget. In fact, it's less than 0.5% of 1%.
Right, and I want you to take that into, because you told me this before we went on the air. This is astounding. The average investment that's going in from the federal government into medical school compared to what the nursing field gets. Give me those numbers again.
So currently right now, the budget of the National Institute of Nursing Research is approximately $198 million. Okay. Only 92 schools of nursing receive any NIH dollars. For schools of medicine, there are approximately 159 allopathic MD medical schools. Of those, about 156 receive NIH funding, and the average amount that they receive in funding is $116 million.
Each school?
Each school. So, that's not what each school receives,
right,
but that's the average,
right.
On average. And then what happens is when you think about the budget of the National Institute of Nursing Research being $198 million, it couldn't even fund 2 schools of medicine, the entire budget. So then so it's the comparator for me is like, sometimes this is where nursing feels like we're on a raft. We hope we have oars, whereas others look like they're on the Queen Mary, on an ocean liner. And in addition to that, so that's about $18 billion last year that went to schools of medicine in total. And in addition, there's also graduate medical education payments that helps hospitals educate residents and physicians as part of that GME payment system. Part of it kind of goes to help pay some faculty salaries. Part of it goes to reimburse the hospital where these physicians are being trained. And it's largely through a Medicare payment system, but it's graduate medical education, and that's another $16 billion that are helping educate the physician workforce.
We are talking with Dr. Annette Wysocki, the Dean of the School of Nursing at the University of Buffalo. As you can tell, there's a lot to get into here in this hour of What's Next. We're going to take a time out, come back, and finish up our conversation with Dr. Wysocki. This is What's Next on WBFO.
Our mission at Buffalo Toronto Public Media is to serve our local community. And on WBFO, we do that by keeping you informed. We bring you important perspectives from your neighbors on what's next.
It's cultural heritage tourism. People go and they travel different places to learn about history and lived experiences that only took place in that area. Oftentimes you may have people in certain positions that don't understand the value of cultural heritage tourism.
And we investigate issues in our community, such as racial disparities and traffic stops.
The data breakdown by council district shows that black people are stopped disproportionately to their population in all 9 districts. Lovejoy District leads the pack in terms of those disproportionate stops. Just 37% of the district's population is black, yet black motorists account for almost 70% of stop receipts issued there.
This is public media.
This is Jack Cruiser with the scoreboard on WBFO. Listen during Morning Edition and All Things Considered each Monday, Wednesday, and Friday for the latest on pro matchups and college rivalries, as well as standout local athletes from Western New York and Southern Ontario. Want more? Listen to a longer version of the scoreboard at WBFO.org or wherever you get your podcasts.
You're listening to What's Next, our place to discuss the important issues of our communities of Western New York and Southern Ontario. We want to hear from you. Click on the Talk to Us option in the WBFO app. and we will work to get your questions or comments on the air. Have a story or concern that we should be addressing? Email us using whatsnext@wbfo.org. Together, we'll have the conversations that are needed. This is WBFO, your NPR station.
And this is What's Next. We're back with Dr. Annette Wasaki, the Dean of the School of Nursing at the University of Buffalo. I want to get into innovation in the medical field and healthcare fields. Maybe that's a better way of describing it. I was fascinated by the story that you were telling about nurses during COVID. I mean, it's a simple innovation, but, the idea of just having a longer IV line so it can that IV can be outside the hospital room, and so fewer people are going to be going in and out, less chance of infection. Your experience is dealing with wounds and burns in your early days as a nurse. Drove you basically into research. And what's interesting is you're saying when you started off in nursing, I mean, it almost sounded prehistoric the way burns and wounds were being treated. Just give us an example of we're going back maybe 3-4 decades now of what the situation was then and how it is now.
Yeah, so I mean, yes, when I first started, I mean, that's what drove me into wound healing as a research career, because I was doing things for wounds that I thought were ridiculous things to be done. For
one example, yeah, please.
One example is we were told to put Maalox on the wound and then use a hair dryer and dry it. And I thought, this is absurd. I had started out my career actually as a chemistry major.
Oh, okay.
Before switching to nursing. And just having that background, I thought, this is ridiculous. This is not biologically, logical. And then that's what really drove me into, because I felt like some of the things we were doing were just absurd. And it was almost like people didn't understand enough about how wounds healed normally to then understand what's going wrong. And when wounds aren't healing normally, how do you do that? So that's what drove me to start to do research on wounds that don't heal normally, what really are the problems, and made some discoveries about what some of those elements are. I looked at a major protein in a wound, which is like a biological glue, and discovered that it's broken down and that's vital to heal a wound, called fibronectin. But then that if you put that on a wound, you can move a wound towards a healing trajectory. But one of the reasons why wounds don't heal normally either is because there's a inflammatory process that drives other cell types to release what we call enzymes, a class of enzymes which we refer to as proteases. And so those proteases then start to digest the matrix material that would heal the wound, the collagen, faster than it can be laid down. So that was some of the research that I did. Eventually, it led to some other product innovations and also some testing, ways to test and monitor wounds to understand if they're on a healing trajectory. So that made it really exciting to kind of bring it full circle at some point.
Frontline observations made a difference there.
Yeah, absolutely.
And just to be clear, if you are somebody who has an old family recipe of putting Maalox in a hairdryer in a wound, maybe you should think of something else. Interesting, though, I guess, research going on at the University of Buffalo right now that are exploring, different paths, different treatments that nurses may be using someday?
Yeah, no, we're doing a lot of great work. We have faculty that are doing tremendous work. So we have one of our, Dr. Carly Arrow-Weiss, who's one of our sleep researchers, who's looking at using a vitamin B3 derivative to see if it won't improve sleep. And she did an initial pilot study looking at veterans with the VA Medical Center, and she's continuing on her study. She's actively recruiting patients for those studies. So if you're interested in knowing and enrolling in a study around discovery of that, whether it helps with sleep, then please contact her. We have one of our young faculty members, Dr. Daniel Smith, who's looking at climate and how it affects health. And he's specifically focused on high heat and human health, and he's looking at whether or not high heat affects kidney function,
Wow.
which has been shown to then sometimes lead to kidney failure. It results in many people that are agrarian farm workers and working in high heat environments, sugarcane fields, pineapples, et cetera, where you might need to go on dialysis because it's affecting your heat. So understanding what level of hydration is needed, how often you should have rest breaks and be in the shade. So actually, he's one of our great researchers who actually was invited to a White House summit over the summer to look at the effects of heat on human health. And so he was actually, I think, probably the first faculty from Buffalo to be invited to a White House summit. So that was really exciting. Dr. Grace Dean, who's now deceased, was also studying when I first came here, again, sleep and how to help cancer patients, recovery, and that sleep and the importance of sleep for human health. And again, remember before I might have mentioned that deep sleep is where growth hormone is secreted that helps to restore tissue health of the body. So that's very important. And likewise, Dr. Weiss's work also has shown that sleep is also important because it helps your brain has to sort of go through, if you will, a cleansing.
Yes.
During sleep, and it kind of helps remove, if you will, garbage out of the brain. And so that sleep is really important. That helps to accomplish that process to have good.
So maybe in the future we can expect to get a little more sleep in the hospital.
Yes, I mean absolutely. So that's some of the exciting research that's going on in the School of Nursing. We have another faculty member, Dr. Eunhee Park, who was recently awarded 2 NIH grants, and she's looking at young adults and teenagers who are vaping and using, smokeless products, if you will, rather than in my day and age it was cigarettes.
Sure.
But using vaping and understanding how that's affecting their health, and then how she can use an app based to kind of help people change their behavior and prompt them, and looking at how just motions of the wrist, and she knows you're smoking, right?
Oh, wow.
Okay, by some wrist motions and other things, and then trying to give prompts to help you quit and avoid smoking. So she's been studying that area and has received 2 grants for that. And we have other researchers like Dr. Sharon Hooner, who's been looking at transitions of care. And that's one of the things that's so important today, where sometimes as people are being discharged from hospital to home, or hospital to nursing home, or hospital to assisted living, where sometimes some of that data doesn't follow you, and then there's glitches in the care and what should be the therapeutic regimens and what we should be doing. And then some of that knowledge is lost. So she's been working with Healthy Link data and is showing that, if you can improve those transitions of care, then you can decrease risk of having to be rehospitalized because the communication of essential information is improved.
We've talked to Dr. Wysocki in our conversation here, and we're coming down to the last couple of moments here, but about maybe kind of a general idea of how perhaps the medical field, or the whatever the healthcare system, could perhaps do more to kind of help nurses who can help patients. At the same time, how about a little thought to just the consumer and their families? What about, again, I go back to my parents' experience. Here are, 4 or 5 siblings jammed in a room here, and, if a nurse comes in, how can we perhaps help a nurse do their jobs better? What could we do? Is there a way that just a treatment that we can do as people are there? Obviously, we all have the same concern. The person who's in the hospital bed. Well, what could we do to perhaps integrate better, or just get out of the way?
Well, I think, I think that, presence is caring. So I think for the family member, sometimes, especially depending on, what that trajectory might be, that presence is very caring. And I think for us, sometimes it's making sure we're informed of things that maybe the patient hasn't told us about. And sometimes family members know other things about their family member that might be important to inform us about, so that we can provide better care. Maybe they might have had a prior accident or some other health deviation that they forgot to tell us about because, they didn't think it was relevant to what they're in the hospital for today. And so sometimes we don't always get complete or accurate histories. So if family members have some of that information, then please share that with your healthcare provider team, so that that might help us inform and understand how we might better care for your family member. And then likewise, it's a two-way street here, because
Sure.
we know this person may be going home, and we're also trying to make sure you know how to care for this person once they're discharged to have the best outcome possible. So it's always a two-way communication. So I always say it's I've never shied away, but I think it's also because I'm from North Carolina, so I'm used to having family all over in the room. And I mean, I know I've been in places where people are like, oh, you can't be here. I'm like, what do you mean I can't be here? But it's just, I think it's a way of life where I grew up is the family were always in the room with the patient, and you just did whatever you needed to do. And I never cared who was in the room. I did what I needed to do. I always checked with the patient to say, is it okay that they're here? Because some patients, again, depending on what you're doing, may not want the family present. So I'm always trying to honor the wishes of the patient first in those interactions. But I'm always used to having family, and I never shy away from doing whatever I need to do, whether the family's present or not. But again, if it's what the family member desires. And patients do need their rest, and sometimes, family members want to be there to show support, but sometimes family members can be exhausted, and then sometimes that's when we have to have a hallway conversation to say, they're really exhausted. Maybe you should just visit a little shorter today so they can get some sleep. So I think it's those types of hallway conversations, again, where we're interacting with families to help support the patient who should be the focus of our attention.
Dr. Wysocki, thanks very much for the conversation today. It's been fascinating.
Thank you so much. It's been a pleasure.
Dr. Annette Wysocki is the Dean of the School of Nursing at the University of Buffalo. She's been our guest today on What's Next. This is What's Next on WBFO.
Support for WBFO and What's Next comes from our members and from Health Foundation for Western and Central New York, where racial and socioeconomic health equity are prioritized. Learn more about building healthier neighborhoods at hfwcny.org.